Good evening, everybody, and welcome to this evening's Facebook Live, Managing Complex Wounds with Single-Use Negative Pressure Wound Therapy. I'd like to first and foremost start by thanking Smith & Nephew. They're this evening's sponsors. I know they've worked really hard to help put this presentation together. So thank you very much to the whole of Smith & Nephew. This evening's speaker is Jackie Dark. Jackie is a tissue viability clinical nurse specialist and the tissue viability service lead, the Great Western NHS Hospitals Foundation Trust. And I've been speaking to Jackie beforehand. I know that she's absolutely raring to go and very excited. And I can see you there, Jackie. How are you doing?
I'm okay, thank you. I think I'll be better when it's sure.
You'll be absolutely fine. I'm really looking forward to hearing tonight's presentation. As always, the certificates for attendance will be available at the end. We will put a link up there. Many of you ask for copies of the slides. They'll be available on our website to download from tomorrow. So do please bear with us until then. As you can see, we're presenting from our homes. So if we've got any technical issues, just bear with us. We've got a team, a very good professional team behind us who will control things. If we do drop off, we will definitely come back. I think that's it for me. So Jackie, I'm going to hand over to you for you to do the presentation, because I know that you're, as I said, raring to go. I'll meet you back at the end of the presentation to go through the live Q&A, which just reminds me, I know that most of you have watched these before and you know how they work, but please do ask as many questions and send in as many comments as you possibly can throughout the presentation. And what we'll do is Jackie and I will have a conversation about those after the event. So thank you very much, Jackie. Over to you. Good luck.
Lovely. Thank you, Alec. Thank you. So as Alec said, we're going to be talking about complex wounds today with single-use negative pressure wound therapy. I'll probably be referring to that as negative pressure predominantly throughout the presentation because it's quite a mouthful to say in one go. Just a little bit about background. Alec introduced me, but equally I just really wanted to just share that I have a real personal interest in skin integrity, having managed sort of atopic dermatitis all my life. And for those of you that may be on the call that know me, I've spent the last, and I hate to say this, 28 years in dermatology and tissue viability. So hopefully I can bring something to the presentation this evening. So I just really wanted to take you through the learning objectives for tonight, and there's four main ones really. Thinking about what makes a complex wound or a hard to heal wound. So what's the definition of that? What the factors are that may influence that wound to become complex or hard to heal. So as clinicians, how would we interpret that? What the impact is both from an economic perspective, so from a larger scale, and then also what is the patient impact. And then through a series of case studies, we're going to be looking at the role of the single-use negative pressure wound therapy in improving outcomes in patients with hard to heal wounds. So looking at specifically at patient impact and then how we manage that using negative pressure. So the question really is, complex wounds, what are they? And you'll be really familiar with a variety of different terminology. They mean different things to many different people. And I guess the most common terminology that we hear banded around is chronic wound, but that doesn't really give the whole picture. We talk about complex or hard to heal wounds. We refer to the complexity of management and healing, and that tends to be regardless of wound type and etiology. So when we are thinking about the terminology that we want to use, we may also refer not just to the wound itself, but the setting or the site that the patient's being managed in. So for example, although I'm service lead for the organisation, I'm based predominantly in the community setting. And so for those of you that are based there tonight, you'll be really familiar with managing patients that maybe are managed with a package of care that's 4 times a day, and then you're being able to arrange to go in and manage that wound is dependent upon the patient being hoisted back into bed to enable you to manage them, and that can be quite challenging, just arranging that itself really. I guess the other thing that determines what we as clinicians, individual clinicians, call complex is dependent very much on our own levels of knowledge and skills and experience, maybe with wounds in general or with a particular wound type, and that may influence on our kind of terminology that we use. So, for example, someone that's not in a specialist service and very much a generalist skills may actually think a wound is relatively complex, whereas somebody who's used to managing that type of wound would consider that being something more, perhaps more simple. So a variety of authors have looked at or made perhaps a more specific definition of what's considered a hard to heal wound or complex wound. And we've got a number of definitions here. So healing that takes longer than anticipated given appropriate therapy, or a wound that fails to heal with standard therapy in an orderly and timely manner. However, the next slide demonstrates a definition that I really like, and I feel it's very relevant to my practice because it doesn't just focus on the wound, but encompasses the patient within that definition. So it really considers the patient impact on the wound and the wound impact on the patient. For those of you that may be listening on your phones, I will read that out to you. So the definition is a wound and its underlying etiology that does not respond to treatment and or the demands of treatment are beyond the patient's physical health, tolerance or stamina. So that was from 2004, but I still feel it's really, really relevant today. However, that's not the only definition that we use, and some of the other definitions that help us to consider whether a wound's hard to heal or not are based on healing rates. So in the literature, we've got some really evidenced healing rates that suggest that for patients that have a diabetic foot ulcer, if that wound is got a less than 50% reduction in 4 weeks, that will be considered hard to heal. For venous leg ulcers, it's considered to be less than 40% reduction in 4 weeks. For pressure ulcers, less than 41% reduction between 2 to 4 weeks. And certainly some of the consensus is that any wound that's not healed by 40 to 50% after 4 weeks of standardized care, so that would be appropriate care for that wound type, should be considered a hard to heal wound. And in that case, then alternative strategies need to be sought. That might be by referral to a wound care specialist or multidisciplinary team. I guess the challenges for us that are already working as wound care specialists is that we've already received them when they're already at that place that they're hard to heal. So it's really about how do we determine what support we need, what other members of the multidisciplinary team are going to help us troubleshoot with this patient. It's really important that we consider re-evaluation and assessment, and also engaging predominantly with the patient too. So having really open and frank, transparent discussions about the fact that it's, you know, that wound is hard to heal, that it's stalled, that it may not be progressing as we wish it to be. I think the other thing to consider is that healing is not the only outcome, and we need to consider those wounds that may be unlikely to heal or where healing isn't a priority. So I think it's really important that when we're documenting our outcomes, that we need to be thinking about other ways of measuring whether that wound's progressing or not. So thinking about person-centred care, it's important that we're engaging with patients to determine what their outcomes may be. So they may be thinking about things like taking a shower, ability to self-care, if they've got a wound that's related to pressure, how long can they sit out for? Can they start to mobilise? Can they continue working? And although it may feel quite alien to us sometimes because the patient choices seem to be not sort of, I guess, in tandem with what we would consider to be our outcomes, it's really important that we consider our care planning around those patient responses. I think the other thing that's really important is that we need to be really specific with our care planning and making sure that our aim is not just for the wound to heal, that we're a little bit more specific about what our intention should be. And it might be to reduce odour or exudate, depending upon what those patients' needs are. So the other thing to consider is what factors may influence that healing process. Now, that's probably a whole scenario in itself, really. So whilst we're going to cover just in briefly a number of factors, there's too much to really consider within tonight's presentation. So as well as the reference list at the end of the presentation, what I've drawn out are 2 documents that I think would be really helpful and supportive in your clinical practice to give you some guidance around these factors that impact so much on the wound itself. So the first one you can see here, the document is a Hard to Heal Wounds Made Easy, and that's by Wounds International. And that really covers a range of the factors that we're going to be talking about now and some of the patient impacts. And that was written in 2011. And then to the right, you can see another document there called Implementing Timers, the Race Against Hard to Heal Wound. And that's a Journal of Wound Care International Consensus document. And literally it is international. So the authors are international. Some of them will be very familiar to you, such as Christine Moffat, Leanne Atkin, Greg Schultz and Marco Romanelli, and that was written in 2019. And both of these documents cover in a great detail all the factors that affect wound healing, showing you different algorithms and things to consider, and how you can troubleshoot and move these patients on so that we can help support them in trying to progress that wound. So they do cover a variety of different elements, such as patient factors. And for example, these would be things like age, additional comorbidities that patient's experiencing that might include medication, it might be vascular supply, it might be social elements. They look at wound factors, so that might include things like wound duration, size, the etiology, infection, inflammation, that kind of thing. In terms of misdiagnosis, that we talk about that in terms of not just getting it wrong, but actually maybe not even having a diagnosis in the first place. So we'll look at a little bit later some figures around the level of diagnostic accuracy in patients, or sorry, in clinicians and managing wounds. And I think it's very easy to assume that a wound is of a certain etiology type, but actually, you know, unless we're really specific in our assessment processes, then we may actually get it wrong. And one of the things that we need to consider that we've mentioned already is about looking at that wound healing trajectory. Now, the only way that you would know whether that wound's progressing using those percentages that we talked about in an earlier slide is if you're actually measuring the wound itself. So, you know, visual observation of a wound and thinking whether a wound is healing or not is not accurate enough, is not an outcome measure. So it's really important that we're measuring the wound, we're able to work out surface wound area reduction and be able to determine whether that wound's stalled, deteriorating, or is progressing as we'd expect it to be. So we need to be thinking then also about clinicians' competency, their knowledge and skills in terms of the wounds that they're managing, perhaps some of the patient's medical conditions and knowing when to escalate and when not to escalate as well. We need to be thinking about resources and how that impacts on managing patients with wounds. And that might include, do we have appropriate pathways for patients? So some of the challenges might be in areas around trying to achieve a pathway for patients with pressure ulcers that require debridement, and how do we achieve that pathway so that they get appropriate treatment in a timely way, such as plastics. We need to consider whether we have access to advanced treatments or therapies, as they may need to be implemented in order to progress that wound. I think the other thing that we really can't deny is the last year, and it'd be remiss of me not to talk about it, and certainly trying to manage patients with wounds within the environment of a pandemic caused its own challenges and complexities, and wounds that perhaps were not normally complex became so because patients were reluctant to escalate, or there were challenges around the clinicians that were managing those patients in terms of capacity. Perhaps some of them may have been isolating. So actually, again, appropriate escalation was not made at that point. So it's something that has made us think about the way that we manage wounds in general, and how can we manage that differently going forward. So we've said that one of the things we would look at is the economic burden of wounds. I appreciate that this is quite a busy slide, so for those of you that are looking at this on your phone, it may not be so obvious to see some of the elements. So I'll just talk through some of the key figures from this slide and the key data. So back in 2012, 2013, Guest and a number of other authors really gave us our first comprehensive evidence around, I suppose, real life data really. And it was based on a practice database, and they extrapolated the data to look at what the national picture would offer really. gave us some great statistics, some great evidence to help us build business cases, to help us put wounds on the agenda. And actually that's been reviewed in 2017 and 2018, and we've got a published update back last year. And I think what's been quite staggering is to see the cost of wound care in general and how that's been increasing even in that sort of 5 years. So we're looking at an annual cost of 8.3 billion on wound management, and out of that 8.3 billion, 67% is spent on unhealing wounds. And when we were just talking about misdiagnosis or a lack of diagnosis, out of those wounds, 25% had no diagnosis. And that's really hard to manage. How can you manage wounds if you don't know what you're dealing with or what the etiology of the wound is and what the expected management should be, what best practice should be, and what the consensus is as to how to manage that wound? What we know, there's a lot of work when we're trying to help build business cases for procurement, when we're trying to support dressing use and advanced therapy use with management, is the actual unit cost of the dressing plays such a small part in the total cost of wound management. We know that over 70% is spent on clinician activity. So one of the biggest things that we can do is if we can reduce some of that activity, we will reduce our overall costs. So when we're thinking about resources though, we've talked a little bit about the impact of resources on the pandemic, but generally we know that there's been a 30% reduction in community or district nursing between the first evidence back in 2012 and also 2017. So we've already got a 30% reduction. We've got an increase in demand. We know that the annual prevalence is increased by 71% over that 5 years, but we've got a reduction. So we've got to do something different to be able to manage these wounds. The other thing to consider is that 71% of those wound care costs occur in that community setting. So that's really where we need to make some of those changes. So the annual prevalence, as we've said, increased by 71% over that 5-year period. And if we move on, the next slide really demonstrates what that looks like when we compare it to other long-term conditions. So what does that look like compared to wound care, compared to diabetes? So this was data that was NHS generated. This is back in 2016, and you can see wound care sat there between obesity and cancer at 5.3 billion. That's now going to leapfrog over cancer at 8.3 billion and be sitting between cancer and diabetes. And equally, we know that that burden of wound care falls disproportionately on the frail and elderly, and clearly for those with long-term conditions and multiple comorbidities. So that's what we see nationally. So it has a huge impact on us. But I think the other thing that sometimes it's hard to consider is how that impacts on us at a local level. So what I want to do now is just take you through some of the impact and the data that we found when we conducted a study looking at hard to heal wounds. So we decided to take 10 patients, and we're going to look to extend that over the next few months with more cases and more data. And we took 10 patients and we decided to sort of analyse by utilising single negative wound pressure therapy, so that's PICO, and use that for those hard to heal wounds. So out of the 10 wounds, as you can see here from the pie graph, 50% of them were known to be deteriorating and 50% of them were static. Over 60% of them had had those wounds for greater than 12 months. And when we look at the guest data, they were found that the average wound duration was around 4 months. So these are slightly longer than that, but it's still long enough for a patient to be experiencing a wound. The wound types that we were managing with PICO were pressure ulcers, surgical wounds, diabetic foot ulcers, and leg ulcers. So the next pie chart really shows you out of those 10 patients, and I appreciate it's a small number, so we're going on to expand that data. What we were able to see clearly is 7 or 70% of them progressed. One or two went on to heal, and one was a non-responder. So, it's clear that, one of them didn't respond to that treatment at the time. So it's about troubleshooting, going back and seeing what have we missed, what else can we do in terms of the assessment. But for those wounds that had clearly demonstrated that they were deteriorating or static. We could see that a large percentage of those went on to significant improvement. And I'm sure if we went on again to look at those now, moving on, that some of those would have, or furthermore, would have gone on to heal. So it was a really positive response. The next slide really clearly demonstrates the impact that using the negative pressure therapy had on dressing changes. So prior to the implementation of the negative pressure, we were looking at an average of 5.94 times per week. So approximately 6 times a week that we were changing those dressings, 6 times a week. When we implemented the negative pressure, we were changing them sort of every 2 to sort of 3 days. When we returned back to conventional therapy, if we went back to conventional therapy before healing, then we were back to utilising it for greater than 5.5 times per week. So again, nearly 6 times per week. So the impact on dressing changes was really significant. We halved that. And when we're thinking about what the biggest cost is, as we've mentioned already, then actually that level of clinician activity has been halved also. So we're going to be really reducing not only the costs, but equally improving those outcomes as we're improving those healing rates. So when we're thinking about the impact on clinicians in terms of dressing changes, that also has a huge impact on patients. And one of the things that we know is that the burden of hard to heal wounds for patients is huge, not just from a physical perspective, but also from an emotional perspective and a spiritual well-being. We see that those patients that explain or kind of tell us about their physical symptoms often express persistent pain. We commonly see excess exudate as one of the key elements in terms of outcomes that they want to address, that and odour. We see that they describe impaired mobility, and lack of sleep is a common theme, often describe fatigue. And clearly, when the wound's infected, that has a huge impact on them, not just in terms of pain, but also, the impact of increased odour and the fact that they may well end up having to take further medication for that. The impact emotionally is huge. So again, that common word distress, that level of anxiety, the impact from an economic perspective on them. So it may be that they've got a reduced income, because they're unable to work, but actually having that wound increases their costs. They've got to go and attend clinic, they've got to maybe pay for taxis, or they've got to drive there. They may decide to reduce the visits from family members because they're embarrassed. So there's a huge amount of issues that they have to deal with. So imagining dealing with a wound that's been there for over a year, and it's important that we consider that as a long-term condition, and we're encouraging other clinicians that we work with and our GPs to consider that as a long-term condition, because the impact is huge. The COVID pandemic has been a hard choice for patients. Do we let people into their homes? Do they allow clinicians to come in and increase the footfall if they're supposed to be shielding, but at the risk of deterioration of that wound? So I guess for many patients, as we've all experienced, there's been some really hard choices for them to have to make. Equally, we know that there's a really significant cycle of depression. We know the evidence shows us that depression can delay wound healing, but equally having a wound that's chronic will cause depression. So we've got this continual cycle that we've got to find a way to actually address. So what I wanted to do was share with you some of the experiences that some of the patients that we managed with the negative pressure experienced, and what the impact was on them from a very personal perspective. So we've talked very generically, but I really wanted to share some of their experience. So the following case studies are really collated from patients that have been managed by either Tissue Viability or a combination of both Tissue Viability and community services. So the first patient I'd like to talk to you about, so this is case study number 1, is a 68-year-old gentleman. So this gentleman is very fit, very active. He cycled, he played badminton, He was a non-smoker. You might look at this image of the foot and consider that he's diabetic. He wasn't. He was diagnosed with quite extensive peripheral arterial disease back in 2018. And that really was because he presented with some deteriorating areas on toes on his right leg. He was diagnosed with polymyalgia rheumatica, although there is some suggestion that actually it may be lupus or systemic lupus erythematosus, which we know is an autoimmune response and disease, and both of them can impact on vessels, both large and small. So he presented originally with these deteriorating areas of tissue on these toes on his right foot. So back in April, this was 2019, they attempted an angioplasty. It failed. They were unable to dilate the posterior tibial artery, so he was unable to have that. So a few days later, they attempted to remove some of the digits. They didn't heal particularly well, so they did further transmetatarsal amputation back in May. And the image that you can see presently on your phones or your computers is really the image, the point at which we received that referral. So we tried a number of different treatments. We tried lava therapy, topical oxygen, and other advanced therapy. And it was a slow progress, but we got the wound to a point where we felt that it was in a better place to be managed, but it had become quite static and stalled. It was still exceedingly painful for the gentleman, and he ended up having to have analgesia at least 30 minutes before each dressing change. So the image you can see here is on case number 1, the initial presentation that we received the patient at. He was originally a community nursing patient, and then they referred him to us because obviously they were really concerned about the level of necrosis and slough. So after 5 months, we of these about different advanced therapies, we got to the point that you can see here. So the image on the right, where you've got a clear image of the wound bed. You can see some granulation tissue, you can see some slough, but that took about 5 months to achieve that. He was really keen to move his life on. As I said, he was extremely active, and he'd pretty much reduced the amount of contact, social contact, he was having with his grandchildren at the time. So the next slide shows you, again, a little bit more detail about this patient's foot at the 5-month period. So you can see here one close-up, you can see one image taken as a perspective, and the area that was quite challenging, in addition to the top, the dorsal aspect of the wound, is the plantar aspect. So you can see with the image on the right that there's quite a clear fissure, and that was really hard, and we weren't seeing any improvements. We had a number of episodes of fungal infection that we had to manage and treat. So that for us was quite a challenge. So we had long discussions with this gentleman because he was still being seen by the vascular team, and they'd offered him an amputation. They felt that even back at the 5-month point when we received the first referral, that it wouldn't heal and the amputation was the only outcome. He was really keen to prolong that and keep his limb for as long as he could. So he was really keen to try any different type of treatment. So we initiated the single negative wound pressure therapy at that point at the 6th month. So after 5 months of moving that wound forward, this is the impact that we had utilizing that negative pressure in 27 days. So you can see that there's a huge reduction in the wound surface area, and that was with only 10 dressing changes. The other image that's so impactful is the image on the right, where you can see that that plantar aspect, that fissure, has really closed in, and we've almost got complete healing in the plantar area. So the gentleman was absolutely delighted, as you can imagine. I mean, the impact for him was huge. We'd helped to avoid amputation. For him, he was absolutely desperate to go on holiday. So he was able to book a holiday with his grandchildren, with his family. He wanted to be able to play football. We were obviously extremely anxious about that. He used his other foot for that. He had his holiday. He had his holiday wearing the negative pressure. He was able to shower much easier than he had been able to with some of the other advanced therapies. And the other thing that was really key and really started immediately was that the dressing changes were pain-free, so he no longer needed analgesia for that. A key element for both him and for us as clinicians that he was unable to self-manage. So his wife would help to change the dressing, and he would then send us emails in regularly, and we would then perhaps see him every 4 to 6 weeks whilst he continued to manage that and it went on to heal. What's interesting is 2 years on, he still has his right limb. So even though it's very likely that he will lose that limb due to the acute ischemia that he suffers, that he's actually had that leg for 2 years. Disappointingly, his left limb is already showing signs, and he's already they're already carrying out angioplasties for him and considering surgery for the left limb. But currently the right limb is still intact, and at least he's had, as I said, 2 years worth of being able to utilize that limb. So moving on to the case study number 2. So I'd appreciate you're probably looking at that image and thinking it's really quite a small wound. However, I just really want to tell you a little bit about this lady's story, because this lady is very fit, well, she's 29 now, but at the point at which she came to us, she was a 28-year-old lady. It was her first baby, and due to breech presentation, she'd had an emergency C-section. Unfortunately, the wound dehisced at day 9, and at that point she was being managed by the midwife, but that only in England continues until day 10, and then the care of that patient carries over to the GP practice and also the health visitor. So at that point, she ended up having daily dressing changes at the GP surgery, which, sounds significant enough in itself, except that this is bang at the beginning of lockdown. So what we ended up seeing this lady was as a result of her having 5 weeks of daily dressing changes at the GP surgery. So we've got a lady who's had her first babe, and she's being asked to go to the GP practice at 7:30 every morning. She's had a C-section, so she's unable to drive. So her husband has to bundle her and the baby into the car to take her to the GP practice at 7:30 in the morning. And this was at the end of March, beginning of April, for her to have her dressing changed. They sit in the car, obviously, while she goes in, and then she comes back out, and that happens every single day. And during that time, there was no change to the wound dimensions or the exudate levels. So during that COVID pandemic, as a tissue viability service, we were asked to deliver overnight a dressings clinic to help support those patients that were unable to receive dressings at the GP practice. And so she was referred to us at that point, and she was referred to the dressing clinic. There was no clinical signs of infection, so we felt that perhaps that dehiscence was mechanical. During the period of her being seen by the GP practice and having delivered her baby, she'd had no shower at all. She'd been unable to shower, and that was one of the key outcomes that for her, that was all she wanted to do. She hadn't been able to walk with her baby. She hadn't been able to take her baby out in the pram. Now, I appreciate during that time we weren't able to socialise much, but she hadn't even been able to go out and do the normal things that mums would do. So she was really low and really struggling with this daily dressing change. So what you can see on the next slide is the initial presentation, which was the wound measured a depth of about, though it's not so easy to see here, of about 2 centimetres. So we discussed the advantages of using something like a PICO system. One of the biggest advantages at that time was for her to be able to shower. So she was really keen to go forward and to evaluate the product. So we applied the single negative wound pressure therapy on day 1. And this is the image taken at day 3, which was the first dressing change. So already we've seen significant granulation tissue, and already we're seeing epithelializing tissue, and the depth was minimal, was just a couple of millimeters. So in summary, for this lady, we've moved this patient on from 5 weeks of non-healing to just over 2 weeks of treatment. During that 5 weeks, she had daily dressing changes compared to twice weekly dressing changes, which could easily be reduced to weekly. So when we're comparing that level of activity, we're comparing 35 dressing changes to 5 during that period of a pandemic when we're trying to reduce footfall for both patients and clinicians. I guess the key thing we've already described for the patient was showering at day 1, and being able to feel like she was a mum again and not be concerned about any leakage, because she was finding the leakage was just coming through her clothing. She felt she could go out and risk, as it was then, a walk with the baby. Yeah, so for her, the outcomes, even at the point at which we utilise the first dressing, was significant for her. So we know that she's obviously remained healed. You can see there from the slide, but also interestingly and happily, she's now pregnant again. So really, huge reduction in activity and clinician costs. So if we look at case study number 3, so this is a gentleman who is a 67-year-old gentleman. He interestingly had a little bit of diverticulitis and hypertension, and that was pretty much all his medical history. So you can see there that he was diagnosed with cancer of the rectum, and that was following a routine bowel screening program. So he was picked up by that routine screening. So it's really great that works. So as a result of that, you can see there that he ended up having an anterior resection of his colon, and they formed an ileostomy. And at the point that the wound was relatively healing, apart from, I don't know if you can see in the top of the image on the right, there's an area of dehiscence at the bottom of the wound as well. So he was discharged and referred to the community nursing team for daily dressing changes. Again, bang in the middle of the first lockdown. So I think, again, we're talking about sort of April time again. Now, this patient was relatively independent, and so the community nursing team rationale was that the patient needed to be housebound, so they felt they were unable to manage his care. The GP practice had pretty much was unable to facilitate any daily dressing changes in terms of staffing levels and in terms of opening the practice up for that. So they also refused. And ultimately, he ended up going back to urgent care for a couple of dressing changes. And at one of their ward follow-ups, they continued then to redress the wounds of both the areas that had dehisced, which meant that he was visiting the ward daily to have his dressing changed. So we've got a gentleman who's just had cancer. He's, again, already been told he's supposed to be shielding, and he's actually going back into a busy acute district general hospital for daily dressing changes at a ward level. So he was referred to the tissue viability dressing clinic for that reason, to try and accommodate and facilitate those daily dressing changes. So we had long discussions with him around the use of the negative pressure, and he was really keen to utilise that because it would allow him, again, to do a lot more, to be a bit more independent. So you can see that we initiated the negative pressure. It's quite a long scar. We did actually use one long one to cover both aspects, so we felt that actually it would support the whole scar line as well. So the first dressing change was day 4, and you can see that the top wound had already healed and epithelialized. So the next image shows the bottom wound that was dehisced, which was also around about 1.5 to 2 centimeters in depth. And again, at day 4, the first dressing change, you can see already we've got some new pink epithelializing tissue, and pretty much that wound has already started to close over. So the next slide shows day 7, the second dressing change, and then also again it shows that patient wound at day 16. And we've already got changes. You can see that the colour of the wound bed itself and the scar tissue has already changed from an acute inflammatory response to that kind of older sort of changes to scar tissue that are shown that there's no inflammatory response present. So that purple hue almost going to that translucent colour. So in summary, this gentleman had gone from, again, 4 weeks of daily dressing changes versus 2 weeks of twice weekly dressing changes. So 28 compared to 3, 28 hospital visits in an inpatient setting to 4 clinic visits. For him, again, the outcomes were huge in terms of showering, in terms of him being able to manage his own time instead of having to be dependent upon other people to come and deliver that care for him. He wasn't always seen immediately when he went into the ward for that dressing change. And for him, he was able to share that one of the biggest impacts on him was a reduction in stress, because he was supposed to be shielding, and clearly if you're going to the hospital daily to have your dressing changed, that's not it's not really classed as shielding at that point. So I'd just like to talk to you about case study number 4. So this is a 71-year-old gentleman. He is a smoker of around about 20 to 40 per day. And the image you can see here started off as a traumatic wound. He fell through the rungs of a ladder and caused a trauma to the wound bed. Before we saw this gentleman, he'd had a couple of episodes of cellulitis warranting visits to either accident and emergency ED or urgent care, the urgent care setting. He developed a hematoma that was excised 4 weeks post the original injury. And then what you can see from the next image was that the area was debrided by the vascular team. They wanted to start compression. They felt there was some edema present, so they wanted to start compression, but they also referred to plastics because they felt that the wound dimensions and the depth of the wound was such that he would require plastic surgery. It was exceedingly painful for him, but you know, he did have good perfusion. There was no evidence of peripheral arterial disease, so yeah, so it was felt that compression was appropriate. So what you can see here is that the image, again, same image as you saw on the original slide. This is the point at which he was seen in clinic. We decided to apply the negative pressure under compression bandages. We know that it works well, it's evidence to work well under compression, and we felt it would help to manage exudate levels and may help to start some of that new granulation tissue and start to contract some of those wound edges. So the image on the right shows you that it's 17 days post-treatment with 7 dressing changes, that there was such a reduction in the wound bed tissue. The wound bed had become so much more superficial. The wound surface area had reduced significantly. So we felt at this point that it was really appropriate to then move on to compression hosiery. So we continued the negative pressure with the compression hosiery garments. So the next slide, you can see the image on the right-hand side, and you can see how much smaller that the wound was at this point. And at that point, we decided to remove the negative pressure, continue obviously in the hosiery for further management, but actually continue with conventional dressings. However, it took a further 3.5 months for that wound to completely heal with conventional wound therapy. So I guess for me, perhaps some of the learning from that is that we probably should have continued further, and we would have got closure at a much earlier stage. However, we got it to this point within 45 days with 11 dressing changes. The key outcome for him was he didn't need any plastic surgery. He was again able to shower before his dressing changes, so that for him was really important. There was significant pain reduction. He was able to travel. He was very mobile. And the thing that was really important for him was that we got a reduction in dressing changes. So as I said, I think learning for me from that perspective was that actually, and perhaps as a team, actually we could have continued for a bit longer because we already had the compression. We knew that we were managing it with standard therapy, which was important, but actually we saw a real, I guess, reduction in wound healing once we'd actually stopped the negative pressure. So for us as a clinician impact, Some of the things that were, I guess, that we found were that there was, we were able to use the choice of filler if we needed to. So depending upon the wound depth, we sort of, for those of wounds that were sort of up to 2 to 3 centimeters, we didn't always use the filler. We didn't feel that was necessary. However, you could if you wanted to, and there was a choice of whether you used foam or whether you used gauze. What we felt, particularly for the surgical wounds, was that there was a lot of additional support, lateral support, bolstering that surgical site and helping to support that wound, particularly in areas such as the abdomen, where there's an awful lot of mechanical stress just by the very nature of the abdomen and how that sits and how large the abdomen may be. We saw rapid tissue regeneration, rapid reduction in wound surface area. Key, I think, was that we were able to reduce dressing changes. We could do that remotely with discussions with the patient without being concerned that we would then get tissue adherence, as you might do with some of the traditional negative pressure. The unit itself is really easy to use. The instructions are really clear. It enabled us to share care with community nursing, with practice nurses, with patients and their family members, and because of the ease of use, really. For us, there was a huge reduction in clinician activity. And as I said, we may well have used it on wounds, in addition to these 4 that you've seen as part of the case study series, in wounds that perhaps we wouldn't have used previously, but because of the COVID pandemic and we were trying to reduce footfall without concerns around the wound deteriorating, we actually did initiate its use. And subsequently, as a result of that, we're using it in a wide variety of wounds that we probably wouldn't have done before. We had increased confidence and assurance, not just in our own ability, but also in the patient's ability to self-manage. And I think it was really important to know that the patients, not only about self-caring, but they were able to troubleshoot and they were able to look at the user guide and know what the different lights meant, and to know whether to contact a clinician or not. So I guess what I wanted to do was just really talk through, those were the clinician outcomes. These are the outcomes that are evidenced, certainly that the industry partner have experienced, as Smith & Nephew have experienced. And for those of you that are not familiar with the single negative wound pressure therapy, there is no canister. It's all absorbed and evaporated within the dressing itself. So what they describe as a zone of therapy, and we've mentioned a little bit of that when we talked about clinician experience. So we saw undisturbed wound healing, but there's that consistent delivery across the whole dressing rather than just actually at the wound. So the peri-wound area and the surgical sites are really bolstered. We see faster reepithelialization and a reduction in tissue damage, particularly if we're able to reduce those dressing changes. We've mentioned wound depth already, so if you're needing to use it on wounds that have a depth where you need a filler, then there is a choice of filler that you can use. For patients and for clinicians, the most important aspect, I guess, was how portable and simple it is to use. And I think perhaps in areas where pathways are a bit more challenging, where maybe higher costs cause, I guess, problems with other areas utilising it. Actually, when you're using something like the single negative wound pressure therapy, because it's all available on prescription, it does simplify patient pathways, makes it easier to discharge patients from an acute setting to a primary care or community setting, and it increases the wear time of the dressing. If you decide to leave it longer, it doesn't matter. We've mentioned already you're going to not get that adherence to the wound bed, but you're also not going to get the same pooling of exudate that you might get with some traditional therapies as well. And what I want to just do in the next slide is take you and show you and demonstrate what that unit looks like for those of you that aren't familiar, and what the typical dressing looks like. So for those of you that aren't familiar and feel that it's quite a new innovation, what you'll see flashing on your screen at the moment is the 10-year sign. So this innovation is really celebrating its 10-year anniversary this month, actually, moving forward. And there's, as some of you will be aware, there's significant guidance from NICE around its use as well, particularly in surgical wounds to prevent wound dehiscence. I think, for those of you that have used it before, but perhaps not in some of these areas that we've talked about today, it may be worth considering evaluating those different wound etiology types. maybe consider using it as an adjunct therapy perhaps earlier than you would do normally. And I guess, you know, from that, going on from that last case study, maybe continuing for a little bit longer. So in summary, the session really today, hopefully it's covered all these outcomes that we were intending to cover. So it's really looking at how challenging hard to heal wounds are for the economy, for patients, for clinicians, and how important it is to use evidence-based interventions to help support patient outcomes. And that's one part of your toolbox really in managing these patients efficiently to try and get them on the right track for that wound to heal. How important it is for diagnosis and intervening at an early stage and making sure that we're assessing wounds so that regularly, so that we're clear whether a wound's progressing or not. And equally, you know, that hard to heal wounds come under a variety of different names. And we've mentioned a number of complexity can mean a lot of different things to different people. So I hope that's given you a little bit of insight into that tonight. And I'm going to hand over now to Alec.
Thank you, Jackie. It was a wonderful presentation. Really interesting. I particularly liked the case studies. I think you've captured some fantastic pictures, which are always good to see, but also just the stories themselves and the way that you've managed to heal those wounds. I'm sure you had some very, very happy patients there at the end.
Yes, very. Yeah, and you forget, don't you? We focus so much on the wounds, and actually we do forget the impact that having a wound has on those patients, and the staggering, those figures and that data that we were sharing earlier, you know, that how many people have had wounds for longer than 4 months, you know, that's a third of a year. And for those patients, you know, they may not have had them for very long, but that activity, that interruption into their normal daily life, just to get a dressing change is so impactful.
Yeah, you mentioned as well, you know, the challenge with COVID and lockdown and things. So it's just added pressure, isn't it?
Yeah.
Listen, I could talk to you all night about this, and maybe another time we will at maybe a conference in the future. But for now, we've had so many people watching and so many questions. I want to get to the audience's questions, if you don't mind. So I'm going to go straight to question number 1, which is, thank you for sharing your case studies, which are great. Are there any wounds which you wouldn't use negative pressure wound therapy on?
Yeah, and I think, you know, we need to be sensible about making sure that we're utilising it appropriately. What I just wondered, does the question specify about the single negative wound pressure, or does it just say negative pressure in general?
It's negative pressure / PICO, so the single use stuff, yeah.
Yeah, so certainly significant depth, even though we've said you can use it with a filler, and although we know that it has good fluid handling properties, for someone with significant fluid loss, and that's continual, and you would need probably the traditional type of negative pressure. Certainly any wounds where there is a consideration of malignancy, then that's something, because of the proliferation of that tissue, then we would need to exclude that when we were using that. But actually, you know, I think utilising it across the board of some of the chronic wounds, you know, because of COVID, it made me utilise it in areas that I probably wouldn't have done before. So I probably would have said to you sort of, you know, this time last year that I wouldn't have used it on pressure ulcers because they're too chronic or they're too deep or they're too complex. But actually we've had some really good results with pressure ulcers too. So I just don't have them, unfortunately, in that series of case studies.
So in theory then you'd use it on pretty much anything?
Yeah. Exudate volume would probably be the biggest, and wound size, because you need it to adhere to the wound bed. So wound size is probably, if it's really deep and there's lots of exudate, then you would need to probably consider conventional therapy.
Yeah, and you mentioned actually just towards the back end of the presentation around sort of how easy it is to use versus other sort of more cumbersome devices and things like that. So I guess that it's just worth people trying, I guess, isn't it?
Yes.
I've got a couple of questions myself around that, but I'm going to see whether any of the audience have asked them first before I get to them. So question number 2 is from Susie, and this is: can you use negative pressure wound therapy on leg ulcers if there is comorbidities present?
Yes. Yeah, I mean, it would depend what the comorbidities are, but what we're doing and what I guess one of those case studies showed was that we could have just gone for conventional dressings and compression, but actually the single negative pressure works really well under compression. There's some evidence to show that. And what was interesting was we continued with that standard care, which was going in from compression bandages, then to hosiery, and we did remove the PICO. And actually, we saw quite a significant slowing down of that healing process. So as I said, on reflection, we probably could have continued that for an awful lot longer. We assume that, you know, it's just the compression that's moved that wound forward, but equally by stopping the PICO, we saw quite a slowing down of that wound healing. Quite detrimental, really. 3.5 months it took to heal, and it was quite a small wound at that point. So yeah, that would have advanced the outcome of that wound healing much quicker had we kept it on for a bit longer.
Okay, thank you. Question number 3. This is from Alison. What about fungating wounds from tumours that have very high exudate levels? These are wounds that are never going to heal, but still need treating.
Yeah, no, so that would have to be done in conjunction with your MDT, because, you know, what my concern would be is that we do lower often pressure when we're using negative pressure to manage fungating wounds because of exudate levels, but we can target and lower the pressure. We would also need to consider, so if you had a large enough area and it was considered appropriate by the MDT, then yes, you could, but it would be something that would have to be in discussion. It's not something that I would be considering doing without that whole MDT conversation.
Yeah, okay, thank you. Question number 4 from Natalie. This is, what do you suggest when you have a hard to heal surgical wound in areas such as when the anal canal has been closed post bowel surgery and you can't get a good seal on a PICO dressing? That's a very specific question there. Let me read that again. Have you got that?
Yeah, no, I think I have got that. I mean, I think it is about tool bags, isn't it? It's about finding things, anything that you can do to add or to shape or to I guess, make it more flexible. You know, we often use gel strips to try and add additional security. We would often use some of the barrier films again, so that you're creating an even better seal. Particularly with the film dressing, you've got the additional film strips. I know, and I appreciate it's not easy, but it is, sometimes you feel it's a bit like Blue Peter, and you're just trying to utilize all the tools that you have in your toolbox. You might be mixing, matching, using other products just to try and secure that. But it's, none of those areas are easy, but certainly they can be. I think it's often easier to utilize the single negative pressure than perhaps some of the traditional pressures, because it's a bit more malleable, and certainly from a patient perspective it's more comfortable.
Yeah, and I was one of the things that one of the questions that I kept seeing appear throughout the presentation was around actually access to the product. So for typical topical negative pressure, normally it's very much a specialist-led prescription, or you know, it's usually ordered by specialists. Is it the same with the portable devices?
No, so it can be, you know, it's available
The
on
single-use devices, sorry.
Yeah, no, so it's available on FP10. So, you know, for those clinicians that feel confident in its use and it's not challenging to use, in terms of that patient journey, it can be used across the whole setting, but equally it can be initiated in any setting. But you're absolutely right. Quite often the traditional negative therapy is usually initiated by either in a hospital setting or by specialists in a community setting. It's not something that perhaps your generalist would use, which might be your district nurse or your practice nurse. However, in this instance, it absolutely can be. It would depend very much on the local, I guess, organisation, the local routes. But if a practice nurse was happy to utilise that, it would just be about a case about scripting and just getting permission from the GP to prescribe it. But I think that's the beauty of it, that it is available to use in all settings, and you're absolutely right, it can be initiated by anyone.
And it's probably about just getting people to start thinking about it as part of the dressing just as part of their dressing catalogue, if you like, rather than a big high-end machine that people need to be scared of. It's just it's another type of dressing that just happens to do a bit more than other dressings.
It does. I think it's about demonstrating the impact, not just on the patient, but the outcomes about clinical activity and clinician activity as well. So we know, we've just said that the cost is, 70% of the cost is clinician activity. So even if you're trying to achieve it, and perhaps somebody's pushing back saying, "Oh, the cost is too great," if you then say, "But we can reduce dressing changes to weekly," and we're going to heal it much quicker. You need to sometimes, because the cost sometimes appears a little bit prohibitive, it's really important those clinicians are able to demonstrate the impact of reducing those dressing changes and achieving those outcomes much quicker.
Maybe you need to provide everybody with copies of your case studies, so they can just flash them at their GPs and at their managers and things, and say, "This is why we need it," because I think they were very, very good. Jackie, that's pretty much all we've got time for. I'm just going to say that if anybody didn't get their question answered, and I know there are lots of you, as usual, what we're going to do is we're going to copy all of the questions, and we'll share them with my team, Smith and Nephew and Jackie, and then we'll write responses to them, create a document that then goes alongside a copy of the slides and the presentation on our website. So you will get your question answered. So if you can just do bear with us. Can I just thank everybody for joining us again? I'm always amazed that so many of you give up so much of your precious time for these events. And Jackie, thank you very much for what is a wonderful presentation. Like I said, I'm really particularly impressed with the case studies that you demonstrated with us tonight. Thank you, Smith and Nephew, and thank you, my team. On the screen now, there should be some links to the certificates and any documents that we've mentioned today. They will also be available via links on the website. There is one final thing that I'd like to say before I leave this evening, and that is that we are going to be back in Milton Keynes on the 7th and 8th of July with Wound Care Today. So for those of you that have been missing seeing people like me and Jackie and colleagues from Smith and Nephew and actually speaking to people face to face, we haven't obviously been able, for obvious reasons, to do that since last February when we had our last conference, but we will be allowed to do it from the end of June. And on July the 7th and 8th, come and join us in Milton Keynes. There should be some information on the screen about how you can do that. We are restricting numbers, so it's 500 people per day. Normally we get much more than that, but we do want to just keep it very safe. So we do hope you can come and join us. Have a good evening. Thank you to everyone involved for this evening. Jackie, I really look forward to doing another one of these with you, and maybe seeing you in Milton Keynes and having a chat about Pico some more over a glass of wine.
Perfect. Thank you. I'm booked. I'm there.
Brilliant.
Thanks, Alec.
Good night, everybody.